Okay, good evening everyone, and welcome to this evening's Infection Control in Practice webinar. So thanks for everyone for joining, and thanks for your patience if you were unable to get on last night as well. So today's webinar then is all about infection control in practice. So obviously with the current situation, the COVID-19 situation, infection control has been highlighted as being a real important aspect of us controlling the virus and protecting ourselves, our colleagues, our friends and family, and our patients as well. But we need to be aware of infection control post-COVID too, because there are often situations where there are infectious diseases within the community, where there's coughs, colds, outbreaks of flus, stomach bugs, etc. So we need to be aware of infection control and hygiene standards so that we can continue to maintain high standards and continue to protect ourselves, our colleagues, our family, our patients throughout the year. So like I say, although COVID has highlighted this for us, we need to take this mindset forward and integrate it into a normal part of optometric practice. So for the webinar today, we're going to go through some slides. I'll talk you through all the information. And then when we get to the end of the slides, there'll be an opportunity for questions. So if you have any questions, just type them in, and then I'll do my best to answer them at the end. If I'm unable to answer them, then we can try and get back to you with some more information later on once I've had a chance to double check on it. But all the links and all the sources of information that have been used to collate the webinar are in the links as well. Once everyone has completed, I'll send out a mass email to everyone with a link to our website that's got a copy of the slides. So you can download the handout, and it will also have a link to the Bondi website. So Bondi have helped us put this together, and they're supporting the webinar over this weekend. So Bondi, obviously, as you're probably all aware, are one of the largest optical suppliers. They have literally thousands of products for everything you need in optometric practice, from frames to nose pads, tools, and PPE. So I've included the contact details for Vij, who's the account manager at Bondi, at the end of the slides as well. And of course, that will be available in the handouts. If you've got any specific questions about PPE supply, or if you want to get some prices or find out a bit more information about their various masks, gloves, aprons, UVC frame, disinfectors and things like that, then by all means give them a shout. Okay, so let's get on with the webinar. So obviously working in practice means that we're going to be coming into close contact with the general public, and that means that we're going to be exposed to germs, to bugs and potential infections. So we're going to look at how we can minimize the risk of contamination to protect ourselves and our patients, and we're going to look at what we'd call the danger zones. So by danger zones, we mean those areas and those situations in practice where the potential to spread infection and to pass on contaminants is higher. So we'll look at the different routes of how infection can be passed, what kind of areas in practice that can happen, and we'll look at ways in which we can minimize that potential incident happening. After we've gone through all that, we'll have a look at inanimate objects, so how infections can pass from objects and equipment. And we'll also look at ways in which we can protect our patients. How do we identify vulnerable or at-risk patients, and what situations and processes we can put in place to protect them in the event of a COVID situation or the outbreak of a cough or flu or particularly nasty stomach bug within the community. And we've also got a bit of a guide about PPE. So we'll go through a bit of the information on what type of PPE you'll need and how to actually use it. Okay, so there's two main ways in which infections can be transmitted. So the first one is via person to person, and the second one is via transmission from a contaminated object. So often with person to person, that can also end up being passed to an object and then to a person as well. So we'll look at each individual scenario and sort of see what we can do to minimize those risks. So to begin with, we'll have a look at person to person. So there's 4 main routes of transmission of infection from person to person. And the first one is physical touch. So this can happen in a number of different ways in practice. So from when your patient comes in, you meet them and greet them with a handshake. Some people even hug their patients. I've never really been much of a hugger, but that might just be some of the places that I've worked, haven't had the most huggable patients. But also when you're adjusting glasses, you're doing adjustments and repairs, etc., to when you're doing up close examinations, you may instilling drops, insertion and removal of contact lenses. There are numerous scenarios and situations where there will be physical touch between yourself and a patient. So physical touch can spread a number of different types of infection. So most commonly we think of ophthalmic infections, and the most common one we sort of tend to come across would be conjunctivitis, whether it's bacterial or viral. But there's also the risk of passing on things such as COVID. But as well as that, you've got things like skin infections. You may have patients with staphylococcus infections, so things such as herpes simplex, skin infections like impetigo, fungal infections, or you can also have things like enteric infections such as gastroenteritis, stomach bugs, sickness bugs, all those kinds of things. But all of the above can all be spread by physical touch. The next one that we come across most commonly is airborne particles. And this again can happen in a number of ways throughout practice. So airborne particles are obviously released through coughs and sneezes, and are also through tests that can disrupt the tear film, such as IOPs with an NCT, as has been ruled out during the COVID situation. Or even if you're removing foreign bodies with an algal brush, again, that's been advised against during COVID because of dispersion of droplets of tear film into the atmosphere. But also, we're also in quite close proximity to our patients. And when we're that close to people that are talking and breathing in close proximity, the chance of airborne particles being passed from those kind of situations is quite high. I mean, we've all come across those patients that occasionally spit when they talk. I'm sure we've all felt that little droplet land on our hand, and we've been, itching to go and wash our hands, but don't want to upset the patient straight away. But that close contact, especially in the test room, especially when you're fitting, repairing, adjusting glasses, and you're taking facial measurements, etc., you are very close proximity to the patient and at a much higher risk of airborne particles. So potential infectious respiratory aerosols are generated when an individual sneezes or coughs or talks. So interestingly, the reason that we sneeze or cough is the same kind of reason that we have things like sores or weeping wounds, etc., when we contract certain infections. So any living organism has 2 overriding evolutionary traits that we've developed, which is reproduction and survival. So when a bacteria or a virus infects a body, the body will create a response to try and kill that virus, which is generally things like temperature, try and burn it out. But the virus has also evolved to create a reaction from your body, which gives it a better chance of reproduction. So, for example, a cough. The cough is a reaction that the virus causes so that you disperse the virus into the atmosphere and give the virus more opportunity for reproduction. So when you have airborne particles that are over sort of 5 microns in diameter don't normally travel more than a meter, but smaller particles can travel longer distances and remain airborne for longer. And again, that poses an even greater risk because once those smaller particles are airborne for longer, they can often settle, land and settle on surfaces, equipment, furniture, fixtures and fittings, etc., which then become a risk of transmission from an object. So airborne particles can spread numerous diseases, such as coronavirus, COVID, and tuberculosis. But we generally commonly think of things like coughs, colds, flus, and those kinds of things that are generally spread. So the next one then is bodily fluids. So we're not going to mention Christmas parties and potential risks of bodily fluids being exchanged and nights out and stuff, but we are generally at quite a low risk of infection from bodily fluids within an ophthalmic practice. So we're at a really low risk of transmitting bloodborne viruses. So things such as HIV, hepatitis, etc. Unless your patients are drawing blood in practice, which I'd hope they're not, however tempting it may be, it's a very low risk that you'd actually come into contact with blood in practice. However, there are always the potential risks of accidents. I've seen in practice before a patient faint whilst having pachymetry done, fall face first out of the chair and land and split their head open on the floor. So accidents can happen and blood can be spilt in practice. So although this is quite a low risk, we do need to be aware of it. Another potential risk with blood is from the use of screwdrivers. So those of us that have ever changed a pair of nose pads or done glazing or screwed a lens in, etc. Probably all of us at some point slipped and stabbed ourselves in the finger with a screwdriver. So again, there is the potential that any kind of infection can be passed via the tools if you do sort of have an accident. But the main bodily fluid that we're going to come across, which can contain infectious agents, is the tear film. So tears can contain contagious infectious agents such as adenovirus, for instance, coronavirus. And these can easily be transmitted to yourself or other patients if your hands are not properly cleaned after the clinical examination. So if we think of situations where we are coming into contact with tears, such as contact lens insertion removal, when we're looking at dry eyes, when we're reverting lids, when we're instilling fluorescein, etc. There's many situations where we can come into contact with the tear film. And if the patient has got any kind of infectious agents, then again, we're at a much higher risk of contamination. But it's important to remember that all spillages of blood and bodily fluids should be cleaned up immediately, and they need to be cleaned with a product that contains a detergent and disinfectant. So we don't use mops, reusable mops or anything like that, or reusable cloths to clean up any spillages. It must be done with disposable paper towels, and they must be disposed of as clinical waste. Okay, so the last method of transmission from person to person would be the use of sharps. So again, this is not something that we tend to come across frequently in practice. And the only sort of example that I can sort of think of that would be common would be, again, the use of things like sharp screwdrivers. So my own personal experience, I've stabbed myself in the finger with a screwdriver previously, and over the course of the evening, my finger swelled up, my hand started to go red, so I had to go off to A&E and get a course of antibiotics. So ever since that incident, I've always made sure I've got my own personal screwdriver, and only I am allowed to use it. But again, it is a very low risk in practice, and if you have communal tools, especially sharp screwdrivers, that is generally the main route of injury through sharps. So what effective measures can we take to minimize the risk of person-to-person transmission? So the number one most important way of reducing the risk of person-to-person transmission is hand hygiene. And you must decontaminate your hands properly and thoroughly throughout the day. So there are a number of different scenarios and times throughout the day where you should definitely clean your hands. So before every episode of direct patient contact or care, as well as after every episode of direct patient contact or care. So whenever you take a patient into the test room, you will always wash your hands as a way of, first of all, demonstrating to the patient that you are following good hygiene standards, but also to make sure that you don't pass anything on to the patient through the examination. However, how often do we wash our hands after direct contact with the patient? Again, probably something you'll do more frequently in the test room environment, but if you're adjusting spectacles, if you're changing those lovely green nose pads, or adjusting behind someone's ears that haven't seen a bar of soap in God knows how long, the risk of potentially contracting contamination or infections from those kind of situations is fairly high. So a lot of the time we probably feel a little bit self-conscious and that we don't want to offend the patient by washing our hands directly after we've been in contact with them. But it's a good idea. And I think with what's gone on recently with COVID, etc., it will be expected. So again, after any exposure to bodily fluids, especially tears, we need to make sure that our hands are washed. So again, you may find yourself consciously needing to wash your hands multiple times within the duration of an examination. After any activity or contact with the patient's surroundings that could potentially result in the hands becoming contaminated. So again, whenever we're in environments where the patients are moving through, whether it's a communal area, whether it's a toilet, etc., a drinks machine, anything where there's a lot of activity, a lot of people to and fro and touching certain items, we need to make sure that we are using good hand hygiene protocol in those kind of situations. After the removal of gloves as well, so we're going to go on to PPE shortly, but it's important that you wash your hands after you've removed your gloves. So again, the gloves are there to protect your hands from getting any contaminated objects on them, but by removing them, you always run the risk of touching whatever is on the gloves. And you'll also probably find that your hands feel a bit sweaty and clammy, and you get all that kind of powder in the inside of the gloves as well. So washing your hands after removal of gloves is a really important step as well. So again, being aware of washing your hands before and after contact lens insertion removal. So again, something we always ask the patients to do, and something we always demonstrate when we're showing patients how to use contact lenses, or especially if we're inserting or removing them ourselves. Number 2 is hopefully a really obvious one, but unfortunately not everyone does follow that sort of simple procedure of washing their hands after the toilet. So not only are you at risk of germs from the toilet itself, but if you have got people that aren't washing their hands going in and out of that toilet room, then there's going to be bacteria, there's going to be all sorts of stuff on the door handles, on the taps, etc. So having good, strict hand hygiene around that is really, really important. When your hands are visibly dirty, and again, as we go on to the next couple of slides, we'll talk a bit about antibacterial hand gel, but it's not often that our hands get visibly dirty within an ophthalmic practice. I particularly hope that there aren't many dirty practices around. I'm sure there aren't, but there are occasions where we could be cleaning out an old filing cabinet or an old cupboard that hasn't seen the light of day for years, or found, various bits of equipment that have been gathering dust. So if we are doing any kind of those kind of jobs within practice, then obviously make sure that your hands are cleaned if they are visibly dirty. Number 4 and 5, again, quite obvious. So if you're making any kind of contact with ocular surfaces, making sure that you're clean before and after. And if you're administering any kind of medication, such as eye drops. So again, when we're in a test room environment, we may have handled equipment, we may have examined a patient, handled equipment, used the keyboard, then we go back, open the drawer, get the drops out and administer the drops. But in that time, we've touched lots of different objects that could potentially have infectious agents on them. So again, that hand washing needs to be done before the final insertion of the drops. And again, after any kind of possible microbial contamination, such as coming into contact with bodily fluids, wounds, or clinical waste. So it's important to remember that when you're washing your hands, that you wash your hands properly and for the correct duration. So I'm sure we're all aware now, we've been told by the government numerous times that we need to wash our hands for the duration of happy birthday twice. But every practice should have a hand washing guide at every hand washing station throughout the practice. So you need to make sure that you are following that guide properly and that you're washing in between your fingers, the backs of your hands, under your nails, etc., so that you are thoroughly cleaning your hands. The quick swill under the tap and the quick squirt of soap isn't really going to have any decent effect. So the proper, correct hand washing technique is really, really important. So antibacterial hand gels. So it's important to remember that alcohol is not a cleaning agent. So you should perform a proper hand wash with soap and water at the beginning and completion of the clinic session, as well as after exposure to bodily fluids. So again, if you did come into contact with bodily fluids, such as tears, etc., then using the hand gel isn't really a thorough and hygienic enough way to clean your hands. You must wash your hands in those situations. But antibacterial hand gels do rapidly destroy microorganisms on the skin surface. But if your hands are visibly dirty, then they will not clean your hands. So again, you have to be aware that it's not a substitute for soap and water. It's also worth remembering that alcohol rubs aren't effective against certain types of novavirus, things like gastroenteritis, etc. So if you are in a situation where you have an outbreak of a stomach bug or something like that within the community, then again, using alcohol hand gel is not really going to protect you from those kind of organisms. Hands need to be washed with soap and water in those situations. But having antibacterial hand gel available throughout the practice is a really great way to encourage patients to maintain good hand hygiene. As you'll see when you click through onto the Bondi website at some point and have a look at their array of hygiene options, there's hand hygiene stations and things like that available, and they should become common in ophthalmic practice. So a lot of practices that we've spoken to doing this session as peer reviews and through various listening groups we've done with XIX, for example, a lot of people are really keen on introducing a hand hygiene station upon entry to the store and asking their patients that when they do come into the practice that they wash or they use the hand gel straight away. But you also need to think about the areas of the practice that could potentially become infected through physical touch. And having antibacterial hand gel available in all those different areas will just encourage patients to use that before they handle frames, before they potentially use the phone, before they use the chip and pin machine, etc. Having it available in all those kind of areas, the dispensing desk, the frame displays, the reception area, it would just encourage that good hygiene ethos within your patients, and it's there for the staff to use as well then. So having it around in all those busy places where patients will congregate, etc., is always a good idea. But it's important to remember that washing your hands and using hand gel throughout the day is also going to have an impact on the integrity of your skin. Especially using hand gel repeatedly throughout the day, it can dry and crack your skin. So it's really important that you maintain the integrity of your skin. So any cuts or abrasions need to be covered with a waterproof plaster, preferably coloured to identify that you've got a plaster on. Normally they're sort of bright blue. Making sure that your hands are properly dried as well. So again, those hot air hand dryers are not really effective. They tend to blow whatever is left on your skin from the water around into the atmosphere and turn it into airborne anyway. And 9 times out of 10, you end up finishing off drying your hands on your trousers or something. So disposable paper towels are the best option to have. Having a towel that hangs up in the bathroom that everyone uses is just not an option. So disposable paper towels are the best clinical way to dry your hands. But also be aware of using things like hand cream as well. Obviously, you don't want to be sharing jars of hand cream with other people, because again, you run the risk of cross-contamination. But maintaining that integrity of your skin, making sure that your skin's not getting too dry and cracked, because you don't want your hands looking old, but you also don't want to damage the integrity of your skin. Okay, so how can we minimize the risk of airborne infection? So the first one is obviously covering your nose and mouth and using a tissue whilst coughing or sneezing. It's important again that when you do use tissues, that they are disposed of. Me personally, there's nothing that that really kind of annoys me more than the sight of a used tissue. So if you have got tissues that you've used, making sure that they go into a correct receptacle, lidded bin, preferably a clinical waste bin, so that they're not at risk of becoming and contaminating other areas. And again, they should be disposed of after single use. You shouldn't be using the same tissue and putting it in your pocket and reusing it over and over again. They need to be disposed of. After you have coughed or sneezed and used your tissue and disposed of it correctly, performing hand hygiene is also really important. So again, this is where having things like alcohol hand gels available, antibacterial hand gels available throughout the practice. So if someone does have a little cough or sneeze anywhere, then there's no excuse why they can't quickly use a bit of antibacterial hand gel and clean their hands. Again, it's just touching on the subject of antibacterial hand gel as well. Of all those hand hygiene stations that we've mentioned, everywhere that you've got a bottle of antibacterial hand gel throughout the practice in all those different areas, put a box of tissues with them as well. And at least that way, if you have got patients coming in with coughs, colds, sneezes, etc., runny noses, there's no excuse for them to not use a tissue. And also make sure there's a bin next to them as well. So the number 4 is a difficult one really, but it is the best thing to do. So if you have got a cold or a cough or anything like that, the best thing you can do to prevent the spread of infection within your workplace is to not come to work. Now, this isn't as easy as it sounds, because depending on where you work, depending on your contract, if you're a locum, for example, if you're not going to get sick pay, then potentially having a day off sick where you could actually feel well enough to plow through and to get on and do the work could potentially result in a lost day's pay, which can have obviously an impact on your lifestyle and your financial capabilities. So the extra sort of stress that can add to people can be a determining factor for them to bring those kind of germs and those kind of infections into practice. Similarly, again, depending on the management, the ownership of where you work, having days off sick isn't always really well appreciated by management. So although you're doing the right thing by not bringing those germs into the practice, it may be seen that you're putting pressure on your colleagues. It may be that a clinic has to be cancelled. It may be that patients have to be rescheduled, etc. And that can sort of impact on you negatively in how you're viewed by management. Certainly in places that I've worked before, where I've had sick pay, even though you've had sick pay and you're encouraged not to bring germs into the workplace, you still have to go through back to work interviews, and you still logged, your attendance is still logged, and you still have targets and etc. and limits to how many times you could be off sick. So although it is the best thing to do, this is where employers, managers, practice owners, etc. really need to work well with their team to make sure that there are protocols in place that it's appreciated that it is the right thing to do and not bring those infections into the workplace. Because when they come into the workplace, there's more chance of other colleagues catching them and that sickness having more of an impact throughout the store as well as the potential risk of passing on to potentially vulnerable patients. So number 5, again, during the COVID situation, it's really been brought to our attention just how often we touch our faces. So subconsciously we do it so many times throughout the day that we really are unaware that we're doing it. However, once you're aware that you're not supposed to touch your face, the urge to touch your face is really strong, but we must resist that urge. So there's been numerous times where I've had to adjust particularly gruesome glasses, and I want to just go and wash my hands straight away, but don't want to upset the patient because I don't want to let onto them that I think their glasses are particularly filthy. But the patient wants to stay around and have a chat, and you can feel an itch on your face, and you just want to itch your face, but you can't do it because you don't want to touch your face until you wash your hands. So yeah, once you're conscious of it, you're a lot more aware of it. But we do have to sort of remind ourselves and be aware that we're not constantly touching our face, especially our eyes, mouth and nose, unless we have just performed hand hygiene. Okay, so what about infection from objects in practice? So we could spend all day listing items that could potentially harbour infection within an ophthalmic practice. There's so many items of equipment that we use in the test room that come into contact with the patient, dispensing equipment, frame rulers, you name it. There's so many things that patients will come into contact with. Everything from a reading chart to an ophthalmoscope, as well as slit lamps, pre-test equipment and all the rest of it. But also things such as frames, keyboards, mice, tools, pay points, phones, etc. Phones particularly because not only are they being touched, but they're also being breathed into. And again, the potential of airborne particles being sort of passed on to the phone as well. So there's so many things within that practice environment that are at risk of becoming infected. So we need to be aware and have good hygiene standards in place and disinfecting protocols in place. So one particular area that's sort of been highlighted recently is frames. And a lot of people are asking, what do we do with frames to keep frames clean? What can we use? What kind of wipes can we use, etc. UV frame boxes and all that kind of stuff. So I think the most difficult thing to begin with is just managing which frames are actually being touched to begin with. So depending on the type of practice setup that you've got, I've worked in small independents where you will select frames for the patient. And I've also worked in huge multiples where you could have 20 people browsing on the shop floor, for want of a better word, picking up frames, putting them here, there and everywhere. So the initial thing that we need to do is make sure that we've got control over which frames are actually being handled. So having a member of staff select frames and then put those frames aside so they can be disinfected before they get put back out on display is really the first step to ensuring that the frames are kept in a hygienic manner. But when it comes to actually cleaning the frames, there's a number of different things you can do. So again, the UVC boxes are really good. Again, if you pop onto the Bondi website and have a look at there, they've got a bit more information about that particular type. There has been some negative feedback about UV boxes with regards to some of the like the cheap ones that are used in things like barbershops and stuff like that. But the good quality ones will do the job. Also, be aware of what you're actually cleaning the frames with in terms of wipes. So you can use non-alcohol based towel wipes. You can use warm soapy water, just antibacterial soap in it and things like that, using that in an ultrasonic cleaner, etc. But as long as you've got some kind of process in place where you can actually disinfect and clean frames, it is really important to make sure that is adhered to. But you've got to make sure that you're not damaging the frames, and that's one of the most important things to remember. So again, avoid anything alcohol based or anything that's abrasive. And if you are sort of putting frames in, submerge them in ultrasonic cleaners, etc., obviously don't leave them in too long so that they become overwashed and start to fade, etc. So what I would advise everyone to do at some point, ideally, we'd like to say before we go back into practice and start testing normally, but that could be as soon as Monday by the recent rumblings on social media. So what I would advise everyone to do when you get a chance is to take a walk through your practice. So get a map of your practice, sketch out the areas that patients will actually go through and walk through that patient journey and just document and make notes of each potential risk of objects becoming contaminated, and make sure you've got protocols in place and items in place where those potential high risk areas can be cleaned. And again, this is not necessarily just test room equipment and dispensing equipment and frames. We're thinking about things like door handles, fixtures, light switches, the handles on chairs, etc. All those kind of things need to be thoroughly cleaned throughout the day with a regular process. But having a journey in mind and understanding where those areas are in your practice and what the patient journey looks like, so you can map that flow of the patient, will just help you to identify those more at-risk areas. So what else can we do in terms of preventing infection from inert objects? So again, number one reason and the number one thing we could do to prevent any kind of infection spread is good hand hygiene. So you can't stress enough how important good hand hygiene is. Clean hands, touching equipment will mean that bacteria infections aren't being placed onto objects for people to pick up and catch them. So the number one thing you should always be aware of is definitely good hand hygiene. Decontaminate equipment after use. So again, in the test room, this can be difficult. There's some equipment that's hard to clean, things such as trial frames, for instance. So a lot of people have suggested recently that they're going to have 2 trial frames, and they'll use one, and then the other one will sit in the ultrasonic cleaner and be cleaned while that patient's in the test, and then just having them alternate throughout the day. But again, something like a trial frame's got lots of little corners and little nooks and crannies that can be quite difficult to clean with a wipe. So an ultrasonic cleaner and rotating and alternating in that sense should be good. But again, all equipment needs to be thoroughly cleaned. So if you think about your diagnostic equipment, your pre-test equipment, just wiping the chin rest and the headrest on the slip lamp or the auto-refractor, etc., isn't really going to be good enough. We need to make sure that we clean the handles, we clean the desk that they're actually on, the chair that the patient's using. Are they pushing themselves up from the handles of the chair? So we need to make sure that all those different aspects are being cleaned as well. So the next one is disinfecting used linen. So again, this is something that's probably not commonly being used in an ophthalmic practice. But since the COVID situation, a lot of optoms particularly have opted to wear scrubs in the test room. So anyone that knows anyone that works in a hospital will know that their uniform, their scrubs, or whatever uniform they have, is not to be worn outside of the practice environment. They're not allowed to travel to and from work wearing those scrubs. And they need to be washed on a 60-degree wash or at least a 40-degree wash using disinfectant along with the normal detergent. So if you are going to invest in scrubs, which again, it is a good option because there is much less risk of taking germs home and passing germs on, throughout the household, then make sure that they are disinfected after each use. You can't wear the same scrubs twice. So for a lot of us who are used to wearing suits at work, ties, etc., wearing the same suit jacket a few days, perhaps maybe some of us have only got one suit that we wear and just change our shirt. But obviously that is going to have to change going forward, and we are going to have to be aware that our clothes are just as much a magnet for potentially contagious agents as any other piece of equipment. But also, like I say, decontaminate the environment. So just be aware of the environment around you, making sure that your practice is clean, not just the equipment, but the furniture, the fixtures and fittings, the floors, etc. We need to make sure that we have got good protocols in place where we are actively cleaning throughout the day. One thing that's difficult to clean, obviously, are things like carpets and cloth chairs. So again, it's been recommended throughout the recent guidelines, which are on the AOP and the college website, that ideally you should have plastic chairs in practice. So again, I've worked places where plastic chairs are the norm in waiting areas, and I've worked at practices where you've got nice comfy sofas and the patient gets to sit and be comfortable, but obviously they are going to be more difficult to keep hygienic and sterilised. So plastic chairs are probably the best way going forward. So let's have a look at PPE then. So all the advice and guidelines that we've got for the PPE are from the AOP website. So if you follow that link, again, when you get the email confirming the completion of the course over the next couple of days, then you can download the handout and you can follow that link as well. But have a look on the AOP website. A lot of the information that we've also gathered for this is from the College of Optometry website. So there's some really good sources of information on there. But they have got all the guides for PPE on there. But the main questions are, first of all, what PPE do we actually need? So the main things that we're going to need in practice are, number one is a face mask. We're going to go into a bit more detail on the face mask in a moment as well. Second is an apron, gloves, and eye protection. So what kind of face mask is needed? So it's important that you get in the correct type of mask. There's no point getting a mask that's not going to give you the correct level of protection. So what the AOP advise is that you get surgical masks with fluid resistance. And these are labelled as type 2R, and they conform to BS-EN 14683-209 or equivalent. The type, why not a type 1 or standard type 2, is because neither of those masks contain a fluid resistant layer, and that is the most important part, so it must be type 2R. So again, you're going to get a lot of people wearing homemade masks, masks that they've sourced through Amazon or through various shops and stuff like that. So patients might be wearing those kind of masks, which will help reduce the risk to a degree, but from your perspective, you need to have the correct type of mask, definitely. So can you use an FFP2 or FFP respirator? So yeah, so both of those will provide sufficient protection, and they are of a higher grade of protection than surgical masks. However, there are some considerations. So the first thing to remember is that respirators are in short supply, and they should be prioritised for those who need them most. So basically those that are actually treating patients with COVID-19. But it's also important to remember that respirators require a fit test to ensure that they perform as intended. So their usage without a fit test may give a false sense of security. So again, with any mask, if it's not fitting properly, then it's not going to be effective. So making sure that you follow the correct guidelines. There's some great videos on the NHS website about how to actually fit and make sure your mask is secure. But if it's not secure, it's not going to give you the level of protection that you need. So making sure that it's fitting properly is essential. So do you need a new face mask for every patient? So you don't actually need a new one for every single patient. So face masks and goggles can be used for the entire session as long as they aren't removed. So aprons and gloves are single use and they must be disposed of after each patient. But as long as you don't take your goggles and your face mask off, then you can keep it on for more than one patient. However, is that going to be practical? Remains to be seen. Obviously, I know through my wife working in the hospital during COVID and wearing PPE, it's not comfortable. You do feel quite hot under the mask and everything, so you are probably going to want to take it off throughout the day. So the chances are that you'll have to have a supply of masks to get you through the clinic. But like I say, they don't necessarily have to change each individual patient. So donning and doffing of PPE. So again, this is really important because although wearing PPE is important, if it's not put on and taken off in the correct order, then again, you sort of negate the effectivity of that PPE. So the question is, in what order should they be put on or taken off? So to put PPE on, first step, and again, first step is the same for every single thing that we spoke about on the infection control webinar, which is hand hygiene. So if your hands aren't clean, your hands haven't gone through a hygiene process, then you shouldn't be touching anything that you're going to use to try and prevent the spread of infection. So always wash your hands before you put your PPE on. Next is the apron, followed by your face mask and your eye protection, finally your gloves. So if you want to think of a little rhyme or an acronym to help you remember these kind of things, that's great. I've been looking at these for the last week or so and I haven't thought of a decent one yet. But putting them on is important, but taking them off in the correct order is also just as important. So the first thing you need to take off is your gloves, and they need to be removed and disposed of in the clinical waste. As we mentioned previously with the hand hygiene discussion, you always need to wash your hands after the removal of gloves. You've just taken off gloves that could potentially have infectious agents on them, and your hands are probably going to be a little bit clammy and sweaty and a little bit of dust like powder residue, etc. So the gloves come off and the hands get washed. After the hands have been washed, then the apron comes off and the eye protection. Then again, you wash your hands. So again, you're touching two items that have potentially got infectious agents on them, and you're then going to remove your face mask, which is in the area where you're most likely to take infectious agents into your body through your mouth. So after you've removed the apron and eye protection, hand hygiene is the next step, the next most important step. So again, always wash your hands before you touch your face. So if you're removing a face mask, wash your hands before you take it off. And then finally, after the face mask comes off, the hands get washed again. So now that we need to think about our patients. So we need to be able to identify which of our patients could be more at risk or vulnerable. And this is the first step in the event of an infectious disease being present in the community. And again, we're talking about COVID, but there are going to be times throughout the year where you've got flus, coughs, colds, stomach bugs, etc. within your local community, and you need to be aware of who your vulnerable patients are and what you can do to identify them and therefore protect them. And not only your vulnerable patients, but your vulnerable members of staff too. So there are a number of types of different patients who could fall into that vulnerable category. And these can include the elderly and the frail, your diabetic patients, people that are undergoing treatment for illnesses such as cancer, chemotherapy, etc., or recovering from transplants or surgery, or people with immunosuppressive conditions or weakened immune systems. So the first couple on there, the elderly and the diabetics, they're fairly easy to identify from within your patient database because you'll have GOS submissions, or you could easily search for a patient by date of birth or sort of filter patients by age. But patients who've got other kind of conditions, you will have that documented within the patient record in the history and symptoms, but there isn't necessarily a flag to alert you to that patient being in the vulnerable category. So one way that we can protect vulnerable patients is to create a vulnerable patient database. So again, depending on your patient management software, or if you're on paper records still, even in 2020, we still have a lot of practices that are on paper records. So if your practice management software has the capability to put a flag on the patient, on the patient's record, this can be done for health conditions, or it could be done for things like accessibility problems, it could be that they're hard of hearing, etc. But a lot of systems will allow you to put a flag on a patient's record so that when that patient record is brought up onto the screen, you can see that there is a condition that you need to be aware of. But another really good way around that is to create a vulnerable patients database. And this can just be done in a spreadsheet or a database software, where you literally just, any patient that you come across throughout the practice that would fall into one of those vulnerable categories, you can add them to the list. And then in the event of an outbreak of flu, cough, cold, etc., and you want to prevent those patients from coming into practice for a certain time period, you can access the database quickly and easily and contact those patients. The next effective way to really manage and limit your patients coming in if they are in that vulnerable category is to have a real good control over your recall. So you'll often find that, especially with elderly patients, that recall letter is gospel. As soon as they get that recall letter, they're coming straight in to book their eye test. And if you have got an outbreak of a COVID or something within the community, you don't just want these people just to come in because they've just received a letter. So having control over your recall, managing and monitoring who you're sending letters out to, who you're sending texts and emails out to, is really important. And if you can stop those letters going out, or those texts and those emails going out, then again, you are preventing that patient from potentially putting themselves in a vulnerable situation. But also, if it's not as easy to manage who's actually receiving the letters or the emails and texts, etc., then putting information on the actual recall to alert them to the fact that there could be a potential risk of infection from a certain virus in the community, and to contact the store. So this can be used in a number of ways as well. So If you have got a flu outbreak or a cough or cold, you can put on the recall to advise your patients if they have got any of the following symptoms not to come to practice, for instance. So again, we often come up with a situation where a patient will come into practice coughing, spluttering everywhere, runny nose, sneezing everywhere, and they've taken the day off work, they've arranged childcare, they've just paid for their parking, and now you're going to tell them that you're not able to see them because they've got a cold, which is obviously going to be a flashpoint and the cause of a complaint from the patient. But sending that information out as part of the recall and advising them, alerting them that if they have got any of the following symptoms, they need to rebook, then again, there can be no real argument from the patient in that situation if we have to advise someone not to come in. And again, as we mentioned before, when it comes to, again, we're talking about protecting our vulnerable patients, but we also have to protect ourselves and our family and our colleagues. And if people are coming into the practice with coughs and colds and potential infectious diseases, then we need to limit that kind of incident, because the more that they bring it in, the more chance there is of us getting it. And the more chance there is of us getting it, that's the more chance of us having time off sick. It's going to put a strain on our finances. It's going to put pressure on the clinic, on the practice. I mean, for the sake of an optom seeing someone with a cold and still seeing the eye test and getting a dispense, but the next day that optom could be off sick, you could have to cancel the clinic, you could lose potentially, you could upset your patient by having to reschedule them, you could potentially lose revenue from those patients having to go elsewhere, or even you could have to lose revenue from getting a locum to cover. So stopping those patients that are bringing infectious agents into the practice is a good business savvy thing to do, definitely. So social distancing within the practice. So obviously everyone's at the moment has probably got their 2-meter graphics on the floor and tape and all the rest of it, highlighting areas that people need to keep apart, etc. But going forward, being able to maintain the social distancing practice, again, it does vary greatly on the type of practice that you're in. But if you can manage the flow of patients, then that will really help with the social distancing, especially during these kind of times and during other incidents where there are potential infectious agents within the community. And the best way to do this, again, is to book patients in. So if you've got patients that are on your vulnerable database, book them in during the quiet time of the day when there's less activity, when there's less chance they'll be bumping into and coming into contact with other members of the community. But also think about collection appointments, fitting appointments, dispensing appointments. Rather than just having the lab glaze or check a load of jobs and then a mass blanket text message goes out to all those people, actually trying to get people to come into an appointment time and managing the flow into practice will really help maintain that social distancing as well. And again, when you've got that control over who's coming into your practice and when, it's much easier for you to manage your staff within the practice. So I'm sure we've all been there where someone's had a late break and all of a sudden everyone gets off the bus to come and collect their glasses. So at least if you've got appointments, you can manage when these patients are coming in and arrange your staffing levels accordingly. The next one is obviously the most important one, is just to maintain high standards of hygiene within the practice. So following all those infection control protocols, the hand washing stations, the decontamination of equipment and furniture and fixtures and fittings and environment, and making sure that throughout the day you are doing everything you can to ensure that your practice is clean and hygienic. So telephone triage. So again, certainly in a lot of places I've worked at, is one of the things we try and limit is the dreaded no-show. The did not attend, the DNA. Those patients that just don't bother to turn up for their appointments. And generally, to get over this, a lot of practices will send out text messages to remind their patients that they have appointments. The best thing to do is to go one step further and to actually phone that patient and speak to that patient and make sure that they actually are well enough to come in, speak to them about any potential symptoms that they may have. And if you want to reduce the actual clinic time in the actual test room, the amount of face-to-face time, then there's no reason why parts of the history and symptoms and some of that can be sort of triaged over the phone. But again, we don't want patients coming in that we don't need to come in. when we're operating on reduced clinics, your chair time is valuable. So you don't want to give up valuable chair time for people that you could potentially advise and manage remotely. And again, when I talk about remotely, I don't just mean talking to them over the telephone, using things like telemedicine software such as AOS, having patients, if they've got a red eye, can they take a picture and send that to you and discuss it, etc. All these different options can come into play, and we can actually manage our patients a little bit better and make sure that we've got the ones that we actually need to see in practice, taking up the valuable chair time. Okay. So things to remember then is obviously that COVID has made us think and adapt, but we must not lower our standards post-COVID. So all the things that we're introducing, such as PPE, such as social distancing, such as these hygiene measures, hand washing stations, etc., these should become part of normal practice. We've talked about getting back to normal, but we're all aware now that we need to get back to a new normal, and we need to set standards that are going to elevate us to a clinical environment. So we've often wanted optometric practice to be seen as a more clinical part of the healthcare system rather than a retail part. So this is our chance now to prove to our patients that this actually is a clinical environment, and coming and seeing us using PPE and maintaining high standards of infection control will just demonstrate to your patients that you value their health. It's important to remember that infection control measures not only protect your patients, but they also protect you and your family, your colleagues, your friends, etc. So infection is not just bad for your health, it's bad for business. We don't want people off sick constantly. We don't want patients getting sick. We don't want our loved ones getting sick. So any kind of instance where you can reduce the risk of a patient or a colleague becoming sick is going to be a winner. Use this time. So obviously we're coming back to the point now where we're gearing up to get ready. And as I said before, due to various announcements that seem to be made on social media and various places, it looks like we could be getting back to routine private tests as quickly as Monday. So we have had a lot of time over the last few months to reflect, and hopefully we've spent that time thinking about your working environment, thinking about what you can do to improve infection control, and thinking about where those danger areas are. But now is the time to really make sure that we implement them. And if you've got any downtime, if you've got longer clinic appointments, if you've got less patients coming to practice and more time to focus on the actual business side of things, then think about what you can actually do to improve your practice and use the time constructively. And obviously use it to do more CET as well. Think about your patients and think about what methods you can introduce to improve infection control from their perspective. So again, we've mentioned face masks for staff, but having patients wear face masks within the test room or within a dispensing environment, etc., is possibly going to be a standard way of going forward as well. So think about what you can do to stop your patients bringing in potential infectious disease as well, because prevention is always better than us having to firefight within the practice. But most important is just be safe and be alert. Okay, so if any of you saw the AOP article, that's Bidge there when he was doing his charity work. So Bidge was supposed to get married during COVID. It's actually supposed to be Easter Monday, but obviously it had to be cancelled, which I was gutted about really, because I was looking forward to that. But he spent his what would have been his wedding day preparing lunches and food for local hospital. So got a bit of good press, rightly so, from that. So it was great to see him sort of sacrificing his time and helping the community in a positive way. So if you want to speak to Bidge, that's his details there. So again, feel free to take a screenshot. But if you want to have a look at any of the PPE that Bondi have got available, or if you want to speak to them and get a bit more detail about the technical aspects of the PPE, then by all means, give Bidge a call or give the office a call, send them an email, and they'll be able to help you on that as well. As I said before, I will email everyone copies of the slides with all this information on. with the links that you can access to get the information where we sourced it from the AOP website as well. Okay, so all that leaves us to do then is just see if there's any questions. So will there be questions that we need to answer, and how would we answer them? So you don't need to answer any questions. We'll have a log of everyone that's been in the webinar and who's left early. So if you have nipped out early and not stayed for the duration, then you won't get points. But if you stay for the duration, then you'll definitely get your point. So, but other than that, you don't need to actually do anything. Because it's an interactive point, when you accept the points on the GOC website, it will ask you some reflective questions. So it's the same for everything that you do on the GOC website when you accept the points. It will ask you what kind of competence have you covered, how you're going to apply it in practice, etc. Is there anything you need to learn further? So that is all that you need to do when you accept the points on the GOC website, but there's nothing you need to return to myself before we can allocate the points. What's your personal thought on the use of gloves? So personally, I would struggle to use gloves as a dispensing optician. I think when you're doing sort of fiddly tasks, like if you're going to try and put a nose pad in and do certain adjustments, you're using frame heaters, you're using pliers, etc., screwdrivers, I'm not convinced that gloves are going to be easy to use. However, in the test room, that might be easier. But again, it depends on exactly what examinations you're doing. So me personally, I think as long as you're washing your hands thoroughly throughout the day and after every patient contact, as we've discussed, then that should be ample. But there is advice that you should use gloves in the test room on the AOP website. But again, I'm looking at it more from a dispensing point of view in that aspect. Any specific advice to keep safe when dispensing under 16s and in particular under 5s? So yeah, it can be difficult, can't it? So having kids maintain social distancing is difficult, and obviously with kids you've got to get a little bit closer, and you've got to more thoroughly check. So again, just hand hygiene really, and if you are getting particularly close to do PDs and fittings, etc., then by all means, pop a face mask on. It might be difficult to get the kids to wear one as well, but yeah, I'm definitely just making sure that hand hygiene all the way, definitely. I have had instances with really young kids where they grab you and they grab your tie and they, all sorts, but yeah, but hand hygiene is going to be the best one in that situation. And we also have a recommendation on the way that you can remember the order in which you need to put your PPE on. So we've had a suggestion: hands, apron, mask, eyes, gloves, to the tune of head, shoulders, knees and toes. So thanks Susie for that one. So yeah, so hands, apron, masks, eyes, gloves. So get that little ditty in your head and then you'll remember how to do your PPE then. Okay, so thank you for all those questions. We will get the points uploaded over the next few days and everyone will receive an email with a link to the downloads and the contact information and the information on the Bondi website. So we'll get those over to you. We've got a few more of these that we're doing over the next couple of days. So you'll get an email over probably by Tuesday. But thank you all for taking part. Hope you all enjoyed it. Hopefully you've all got something that you can implement into practice and some good ideas. I think the best advice I can give other than hand hygiene is to talk to your peers. So when this whole situation kicked off, one of the companies that we work quite closely with is XIX, who practice management software based in Scotland, and they set up a series of webinars and discussion groups for their customer base. And I was lucky enough just to help out and help facilitate some of those. And it was really eye-opening, and it was a really good way of bringing the community together and sharing ideas about what we're going to do when we go back to normal, etc. So build good relationships with your practices in your local area. There may be times where you need to borrow PPE. There may be times when you need to lend PPE to someone, etc. So, let's build up a bit of a community, talk to each other, share our ideas and experiences, and then we can all move on and hopefully get back to our new normal soon. Okay, but thank you everyone, and we'll see you all soon.